Thank you. I will admit you first. I am honored today in coordination with the Dr. Nishit Shah to present this meeting via the Zoom and hope that you will be satisfied and cover all your imagination and the questions about how to treat the CSF rhinorrhea. Please, Dr. Nishit. Dr. Nishit is one of the brilliant endoscopic skullbase surgeon in India. He is from the Mumbai and working in the Bombay hospital. Can you start now, please, Dr. Nishit? Thank you.
Thank you so much, Amar. First of all, Eid Mubarak to all our friends in Iraq, in India, and from wherever else in the world you are.
Thank you.
Hope you're all doing okay. So today we're going to be basically doing just endoscopic CSF repair. I think we'll leave reconstruction for a different day because it'll become too much. Also on Wednesday, I think day after tomorrow, we're going to do a striker symposium on reconstruction. So maybe I'll give you a link for that and then we can cover both areas. So let's go to endoscopic CSF repair. I do work in Mumbai, in Bombay. Essentially, most of our work is done at Bombay Hospital. Right, so if you look at etiology, most, I would say that of our patients that we see for surgery are spontaneous leaks. Now, the spontaneous leaks are leaks which may be high pressure or normal pressure, but more often than not, they're high pressure leaks. And they could have been high pressure leaks secondary to a tumor or primary because of erased intracranial pressure. Traumatic leaks could be accidental or surgical. Again, very likely that traumatic leaks will heal by themselves. And that generally speaking, we don't need to do much in terms of repair or surgery when we are tackling traumatic leaks. When do we decide that surgery is required? I think, and that would be different in different situations. One, of course, general condition of the patient dictates whether he's fit for surgery or not. Two, in the first 5 to 6 days with conservative treatment, is the leak reducing? If the leak is reducing, then we would just continue with conservative treatment and not worry too much about surgery. And three is if there are large breaks, which we feel are unlikely to heal with conservative treatment, then we would go in quickly with surgery. So if large breaks or not responding to conservative treatment, even after 5 to 7 days. Iatrogenic leaks, on the other hand, if you realize on table that you have a leak, then I think you should repair it immediately. That's the best time to repair it. And if you realize only post-operatively, then I would suggest you do a CT cisterno so that you can locate the site of leak. And depending on the situation, if it's a very tiny leak, you could do conservative treatment and again likely to heal, but otherwise go in with surgery. Taking the patient into confidence, very important that the patient is aware why you're keeping him in hospital longer or on bed rest longer. Right. So diagnosis. More often than not, when you see a patient of CSF and you ask him to bend down, you will get a drip of clear fluid on one side. So usually CSF is unilateral, very rare that it's a bilateral. Glucose is something we used to do in the past, not very reliable, and so we don't really depend on it today. It's more beta-2 transferrin or beta trace, which is even more specific. Endoscopy could be combined with this. Of course, it's difficult to locate the site, but at least you know the presence of fluid in the nose. And if you do it with sodium fluorescein, then of course it's even easier to confirm that there is a CSF leak, one, and where the general area it is from. Today, I think once we have a clinical diagnosis, then we're going to depend mainly on radiology. For me, you have two options, right? CT and MRI. So when do you do a CT? When do you do an MRI? We know, of course, CT is essential when you're doing any PNS surgery. And you can't do PNS surgery unless you have the bony landmarks to navigate your way through to the area, to see the break itself. MRI is not so good with bone, but an MRI T2 weighted, what we call a CSF spin sequence or an MR cysternography, will also be able to determine that there is a CSF leak or not in a very, very high percentage of patients. So if you do a plain CT cysterno with an MR cysterno, then you have a sensitivity of almost 98%. For me, however, the gold standard remains a CT cysterno. This is for two reasons. One is I know the dye that I've injected into the lumbar spine is come into the nose. I know it is one site. I know it is one break, two breaks. I know the quantum of the flow, and I know the size of the bone defect very clearly. The advantage of doing a combined CT-MR is that, one, you don't need to inject anything. You don't need to do a lumbar puncture if you're doing a plain CT with MR. And in those patients who are scared to get a lumbar puncture, or in whom there is a spinal situation which does not allow you to do a lumbar puncture, then of course a CT-MR is it's an equally good option. If you have a encephalocele or a part of brain herniation, then it's essential to have an MR to see what kind of vital tissue is in your nose. Also remember, there's a great predilection to do limited CT scans. Please do not do a limited CT scan. You must have triplanar scans, because you don't know whether you need to open the frontal sinus. You'll need to have a proper reconstruction of your anatomy. Don't forget also to do a brain scan, because you don't want to miss out like a brain tumor in the back of the head, or you want to see your ventricles properly. You want to see for signs of intracranial pressure properly. So all these things, MRI additionally will also tell you the status of pressure, both in the ventricles and the optic nerve area. So again, first choice for me is CT cysterno, second choice plain CT with MR, just to show you some scans of cribriform break defects and what it would look like with cysterno or with the dye coming down post repair. Right, so for traumatic surgery, we would conservative treatment, as we said initially, would be our dictat: bed rest, head elevation about 30-40 degrees, no straining, laxatives, diuretics. You can do intermittent lumbar punctures or even put in a lumbar drain. The role of antibiotics is a little controversial, and by and large, the neurology people prefer not to give it unless there are other, let's put it another way, sorry. For traumatic, you'd give antibiotics because there is trauma, so the chance of infection is higher. For spontaneous, the role is more controversial, and you would avoid giving it in all patients. Surgery can then be transcranial, transfacial, or endoscopic. So if I would have a very large defect with brain herniation, if I have a frontal sinus posterior wall, if I have bilateral multiple breaks, to me, these become indications to go transcranial, or tend to go more transcranial. Transfacial is something that we used to do in the past. We used to do like a Lynch-Haworth, and that would give us access both to the ethmoid and the frontal, and we could then repair both frontal and ethmoid leaks. Today, almost all repairs can be done endoscopic, except for a very few of these, which we mentioned earlier. Timing of surgery, we discussed with the prior scan, so I won't go through it again. For spontaneous CSF leak now, this is a different ball game, right? So CSF has occurred, there's no history of head injury or trauma, so you know there's raised intracranial pressure or a congenital dehiscence, which is now opened up. Imaging has confirmed it, and just as water falling on a rock would tend to make a hole, there's no chance of healing. So we do not consider conservative treatment in spontaneous CSF leaks. It is always surgery, and there are situations where it can be intermittent. So you feel that a little bit of diuretics and stuff have stopped the leak. Typically after a CT cysterno, because of the chemical reaction of the dye, the leak will stop or slow down and give you a false sense of confidence that, okay, everything's fine. But To me, these are actually more dangerous times when the active leak is stopped, because your chance of an ascending meningitis then increases. So I would always want to counsel the patient for a surgery. So one problem that we face sometimes here is spontaneous CSF leaks, where the patient presents to you without an active leak. So then you can't do a CT cysterno. You may or may not have had a history of meningitis. And then you can do the plain CT with an MR cysterno to give you some idea, depend on the history, whether it's left or right. If you're still not getting any clues, your CT does not show you a well-defined defect, then you may need to rely on one sodium fluorescein during surgery. If that also does not show you the site of leak, then you may need to do what I would call a carpet graft. That means right from the back wall of the frontal sinus to the anterior wall of the sphenoid sinus. Cover the entire fovea from septum to lamina. Material. So in the initial days, we used to use a lot of muscle. Now we realized that muscle sort of, after some time in those patients which required revision, became a little bit of dissolved into a little bit of a reticulum. It didn't stay solid. Fat, as you know, all of us have struggled with, is difficult to get rid of. You know, it stays as fat, stays like a nice solid piece. So now we tend to use fat more than muscle. Fascia lata provides us, especially in this era now of skull-based reconstruction, we want bigger and bigger pieces of lata. So by and large, we would go more to fascia, either from the thigh or abdomen, as compared to a temporalis. Pedicle flaps, again, being order of the day in larger defects. So yes, for skull-based reconstruction, more pedicle. For CSF leaks, more free repair unless they're large defects. Cartilage and bone, for large defects, certainly we would use cartilage or bone, but not so much for anything else. Sorry, just give me a second. Yeah, Amar? Oh, I see. So how do I do that? Admit all. Okay. So should I go back and start again? Okay. Okay, okay. I got it. Thank you. I'm so sorry. Hello. So I'm just going to go back to a little bit. Let me just get it. So Amar just informed me that now, since I am the host, I need to admit you also. I was just getting that information. So for some of you who have now joined in, maybe I can go back a little bit and just take you through that earlier bit if you missed that discussion. So I'm just going to step back a little bit. Okay, so very quickly to just brief you, we went through etiology, trauma, and spontaneous leaks. Traumatic leaks could be accidental or surgical. Diagnosis is from clinical, from positional, from beta to transferrin, endoscopy with or without fluorescein, CT and MRI, CT cysterno being for me the gold standard. Equally good is a plain CT with an MRI cysterno or a T2 weighted. Don't forget to scan the brain to rule out any other pathologies. Traumatic, mainly conservative surgery if a patient is not responding or the break is large. Spontaneous, always surgery. We don't want to sit on or waste time. Materials to use for repair are these, which we've just gone through. So fat more than muscle, fascia, pedicle flaps for large defects, cartilage or bone again for large defects, turbinate, if you do have the option of using a turbinate, in case you have resected the turbinate, only then you need to use a turbinate. Only then you need to use turbinate. I would not take out a turbinate especially to use. Fibrin glue we use almost always in all our cases, and dura substitutes now more often, but in skull-based reconstructions, not so much in CSFs. So this is just to give you a little glimpse of anatomy, just, you know, a little bit of what your olfactory and what your cribriform looks like. So this is a patient of mucor actually, where we resected the whole septum, and you see olfactory filaments, you see the anterior ethmoid, and you see the entire medial cribriform plate, and you see how extremely thin it is, both in the medial and the lateral parts, as compared to what the fovea would look like. So of course, when this mucosa intact, you would see just the impression of these olfactory tracts and not the actual entire nerve itself. Okay. So we'll try and go through some cases or locations from anterior to posterior. So I'm going to go with cribriform plate first. So if you have something like this with an anterior sort of location, medial cribriform, or this case on the right side, there are many ways you can do this, right? You can take out that, and again, just before I say how to do it, typical location is junction of middle turbinate and superior turbinate. That for me, 80% of these cribriform, medial cribriform leaks will be at that location. So you could do, you could remove the turbinate and have a big access to this area so that you can repair it. But that would also mean that you then have to clear the entire sinuses, because I don't want my fascia going across and blocking the frontal sinus. So for me, it becomes a little large surgery. For me, the easier surgery is just to lateralize the middle and superior turbinates, see the site of defect like this, and repair it. So this begs the question that if I'm going to lateralize this turbinate, will I get synechias? Am I actually closing off the middle meatus? And one has to be careful when doing this, is that not to look in this area, not to touch any or do any instrumentation in this area. If you have no raw areas on the lateral part of the turbinate or the lateral nasal wall, then you cannot get synechia, because synechia can only happen when you have two opposing raw surfaces. So that's why this works for me. So I'm just going to quickly show you how we would do this thing in our center. So middle turbinate being lateralized, and these are patties using xylocaine with adrenaline. The meningocele then gets isolated or delineated. You see the sphenoid sinus at the back. So superior turbinate has also been pushed laterally. I would just widen that sphenoid sinus a little bit so that I don't have blocking of that sinus. You can see now very clear that CSF coming out of that pseudomeningocele. So just a little bit of widening of that sphenoid without taking any part of the pedicle of a flap. So in case your graft or your flap, something slips down, you don't want to block that sphenoid. The meningocele is then cauterized, and the entire surrounding area is marked out so that you know how much of debridement of tissue you need to do all around that original site of defect. Now, the mucosa must be removed well, because you don't want your fascia to sit on mucosa. It will not stick. It will not do well. You don't need to actually take the periosteum off completely, but the mucosa must go off completely on all sides. So at least a centimeter and a half in all directions, medial, lateral, anterior, and posterior around the defect. More often than not, the bony defect size is extremely tiny in these defects. And so it's, you know, once you sort of cauterize that meningocele, it tends to close, and you don't need to do any plugging of it. And trying to plug it would only, to my mind, make the defect bigger. And so I would plug it if the bony defect is large, or if after cauterization and after we've removed that last bit of meningocele completely, the leak doesn't stop, then yes, I would cauterize it. I mean, I would plug it. But if the leak stops completely, I would not, I would just put an overlay on top of this. Now, in our case here, the defect was a little bigger and it did not stop. So we did use a fat plug and we plugged the defect. Again, you can use a bath plug like what Wormwold would do, but if it's a tiny defect, I'm quite happy just to plug it and put a little bit of fat here. Sometimes the roof is conical and then the fascia, if you put it, it leaves a dead space. So a little bit of fat just to make that conical into a little more rectangle, to more flat area, helps that to remove that dead space. So when you do put your fascia in, it sits well against all the walls. So that's the fascia. Again, we typically roll it on a piece of gel foam, and that makes it very easy to introduce, to put, and to open up. In fact, you don't even need to remove the gel foam because you don't want the two edges of the fascia to come back together. You want the gel foam to keep the edges together against the turbinate on one side, against the septum on the other side. And once that's done, then you could put a little bit of tissue glue on top. And in this case, I'm just putting a little more fat again to keep the two edges apart. And then you can put a little bit of gel foam as a buffer, because when you put a nasal pack to support your repair, you don't want the pack to pull on the repair area when you're removing it. So a little bit of buffer, be it fat or be it gel foam, is good between that and the nasal packing material. Another option which you can do, which we do sometimes, is to suture this turbinate back to the septum. And that does two things for me. It means I don't need to pack at all, and it opens up my middle meatus. And these patients can now be mobilized a lot quicker. So we would give them maybe a couple of days of bed rest. So you see, just getting the turbinate away. In this case, I didn't suture it. But if I did suture it, I don't need to pack. I can mobilize in 2 days and the patient goes home on the 4th day. Right. So that is cribriform. We'll go ahead from here to a lateral cribriform. Now, as you see here, right, that's the septum, that's the turbinate, that's the lateral part. So this part of the bone is a medial cribriform. Between the turbinate and the fovea is the lateral cribriform. When you have a lateral cribriform break, and therefore it's important to distinguish between a medial and a lateral, it means I can't do this approach. I have to then do an fess. I have to clear the ethmoids, and only then can I have access to my defect. I will look at my anterior ethmoid because that gives me some kind of guide as to am I anterior, posterior, how far back, or between the anterior and the posterior ethmoids. This patient also had an MRI, so you can see a small meningocele coming out of that into the ethmoid area. Okay. So let's look at this video. So here we've already done the ethmoidectomy just to save time because we want to show you lots of videos. And we can now start seeing that small meningocele coming into view. So very gently, I'm removing the last bits of bony partition around it so that I can now clearly distinguish the meningocele. This is the middle turbinate. We are on the right side, lamina on this side. Again, we are not so careful about preserving mucosa in these situations because actually we want the mucosa around this area to be removed. So once all those bony pieces are gone, we then have a clearer view of the defect. We will note that the anterior ethmoid will be in relation to it above it, and the ground lamella will be posterior. Right. So that's our close-up view of the defect. So I'm going to go a little quicker here. So that clearly defines your anterior ethmoid just above it. So you know again from here, anterior ethmoid defect. Okay, so we just had a quick check to say that middle. So, in this sort of situation, I just wanted to have a quick check medially to see that there is no leak or no defect medially either. And then once that's done, then we can just go, sorry, I need to keep adding this. Once that's done, I can then go very quickly. How to do this. Right. So let's go. So I opened up the posterior ethmoid as well. So now we got a nice clear ethmoid cavity all the way from frontal back to the anterior wall of sphenoid or orbital apex, lamina, cauterize the meningocele, identify the defect clearly. In this case, we want to little bulgarize that middle turbinate so that this part stays open. Right, and then we can put in, so I think, let's go back a bit. Right, so we would just put in a little bit of fat in there, plug it again, like you saw that medial cribriform thing. And then we can go back and put in our roll of fascia. So that's the fascia now going over it and being unfolded. So that you have a nice wide coverage. You don't want to be short, and that's why I like the thigh, because it allows you to take a bigger piece. You can always trim it, but obviously you can't lengthen it. So we can go all the way from the back wall of the frontal to almost the ground lamella, so that we have a nice big cover of it. And once that's done, in the earlier times, we used to have two settings for tissue glue. We used to have a slow setting glue and a fast setting glue from Baxter. This is Tissile. So here we are using the slow setting glue, and this would give me 30 seconds of time after putting it in to put the fascia back into position and squeeze all the glue out, because you don't want any glue to stay between fascia and bone. You want it right against. If you have only the fast setting glue, then you can't do this. You have to have it only above the fascia. You can't then have it under the fascia. And then on top, you would just cover it with, as you saw earlier, with a little bit of fat or tissue glue more on top and gel foam, and then you'd put your pack in there. Right, so let's go to iatrogenic leaks from here, because this is common. I'm just going to go off the screen for a second. I'm not sure whether we got, yeah, okay, sorry. Play. Okay, so let's go to iatrogenic leaks. Now, this was a patient in our very early days. I had a patient who had a very large concha bullosa. So we've done a conchoplasty, and then Medtronic had just come out with this drill, from the blade. So I wanted to flatten the edge of that conchoplasty. So I used this, what you can see is a very aggressive thing, because that was the only burr that they gave me, and sure enough, it slipped, hit the cribriform, and I got a small CSF leak, completely uncalled for. But now that I have it, of course, I had to deal with it. So the first thing you want to do is to get good hemostasis when you have an iatrogenic leak. And often you will see water in a pool of blood that will tell you that something's not right. And it can be very difficult to identify, to locate that site of leak when there's bleeding. And again, bleeding is one of the primary reasons why you've got the leak, right? Because you've not been able to have a clear picture of what you're doing. So before you plug it with fat like this, get good hemostasis. Take your time. Once you get good hemostasis, it's easy to identify the site of leak. It's easy to plug it. I would even say that if you want, you finish your surgery, get hemostasis, then you plug it, put your fascia and pack it. Because once you've done a repair, then you don't want to be doing in and out with surgery. So here we were lucky, since I had removed the lateral part of the turbinate in a very large piece, that I could remove the mucoperiosteum off the turbinate, and we could use that to close the site So I didn't have to give her any additional incision anywhere else, and it was all just middle turbinate mucoperiosteum used. Of course, we had to inform the patient that this is what happened, and I think more often than not, when you have a complication, if you're sincere, if you're honest with the patient, if you explain to the patient what has happened, and the patient sees your sincerity and efforts to deal with the problem, you should not have a problem. The problems come when the surgeon tries to hide a complication and is not honest with the patient. So I think that's what the message should be to everyone. Okay. So I'm getting a little confused here. Okay. So this is another patient with an iatrogenic leak, and I think I'm showing you these because it's not uncommon, or one should not be scared when you're operating. So for me, a good fist surgeon is a person who can do a CSF leak. If you are scared of a CSF leak, you will never clear the skull base properly because your fear will prevent you from going to the skull base, which means you're going to have remnant disease in the skull base. If you want to do a good skull base surgery, if you want to clear your skull base clearly, you cannot be scared of a CSF leak. And so it's essential that you be able to do that. Now, this was another patient. I'd finished almost everything, polyposis, last bit of opening of the ground lamella into the posterior ethmoid. Again, a technique which we've abandoned since. You saw the forceps went in and then we sort of rotated it. And I had not picked up that the posterior ethmoid skull base was very low lying. So the moment I rotated it, I hit the roof and I got a big gush of CSF. So I had to go in and to clear up the entire ground lamella, clear up the posterior ethmoid completely, and then locate the site of the leak. So of course, I can see here that the leak is profuse, but now you see the ethmoidectomy is done. I can now see the leak clearly, and then I can repair it in exactly the same manner that we did the earlier repairs. We plug it with a bit of fat, and then we'll put a fascia lata on top of it. I informed the patient after surgery. Our patient's daughter was actually a doctor, and had, fortunately for me, taken almost an hour to discuss all potential complications with the patient prior to surgery. And everything went well. Healed well, and he understood and was agreeable. Right, now this is a patient, actually this is the only patient which is not mine. Huge bilateral traumatic defects, huge. I mean, this is not, I mean, to my mind, a small simple error of going there and fracturing a skull base. These are huge defects, and to have these kind of huge defects in not one part, but in two different areas, it's really scary. It's frightening to have a situation like this. So I told this patient that actually a doctor came with the patient to me, and I told them that there's no way I can do this repair. You have to go in transcranially. It's just the simplest way to close such a big defect. There's brain coming down into the foveas, as you can see, a big huge block of brain. And the patient said, no, we only came to you because we want endoscopic. So after much discussion, negotiation, I said, okay, I will attempt it, provided you give consent for a transcranial repair if I'm not happy with my repair. So based on that, we went in, and patient had a septoplasty as well. The surgeon had given him a septal perforation as well. So I was now a little worried about how good a Haddad flap I'll get, because I mean, this I need a half flap, right? What kind of cartilage I'll get to repair it. So there were so many concerns before getting into this kind of repair that you could imagine. This is the view on the right side. You could imagine that I was not at all very keen to do this. So we just assessed it on both sides, and then I'll show you the repair only on one side. So this is the entire ethmoidectomy. Middle turbinate was still intact, some amount of surgery done here, and a very large part of the brain coming down. first thing for me to do is to get landmarks, is to get my sinuses. So I'm going to remove that little bit of remnant uncinate. I want to find two things. I want to find my frontal sinus and I want to find the maxillary sinus so that I know where my landmarks are. Again, let's go a little quicker. Let me get all of you back inside here. Right, so we're just clearing up the frontal recess area so that we have a nice, good open frontal sinus. So once you've got a frontal sinus here, you can see my suction entering, right? So that part is looked after. I then need to come down and get the maxilla. So now we're just removing the little bit of remnant part of the uncinate inferiorly and taking that part out. So now I've got maxilla, I've got frontal, I know where my lamina is going to be, I know where the septum is. Now I need to deal with the actual problem. I'm also studying the middle turbinate to see what kind of flaps I can use, etc. So my mind is taking in 3 different directions, even as we operate on this patient. The initial idea of decompressing the lesion with just bipolar, and you've seen the meningocele just compress completely, did not work at all because this was solid brain tissue. So I took a knife, I incised it, still there was nothing I could do. So then we took the decision, of course, all these surgeries are done with a neurosurgery colleague. We do as a protocol, as a routine, all CSFs with neurosurgery. So I did this unthinkable step of taking a debrider, and we're actually debriding the encephalocele. We have done, you would notice, an MRI to ensure there's no major vasculature or vital structure in this. And only then do I have the courage to do this kind of reduction of the encephalo. So once you've removed the bulk of it, and I'm starting now to see the posterior margins, the medial margins, then the last 20% I can shrink with a bipolar forceps. So that's what's going on now. We're just shrinking the last bit here. And I can then start removing the mucosa around this area again so that I have a nice clear edge. And I want to see the bony margins around the defect. So you can see the posterior margin now coming into view. Similarly, I want the medial margins, the lateral and the anterior margins. So mucosa being removed for 2 reasons, for the graft uptake and for the edge of the defect. So once that's done, now of course I realize that it's a super huge defect and I will need what else. So that's my septal perforation, which means that's the anterior most part of the Hadad flap that I can get. So we say, okay, let's see how it goes. I will need, remember, a bilateral flap. The septoplasty is done. The 2 mucoperiosteums now are stuck together. So I have to elevate it without tearing either side. And I cannot come more anterior than this perforation. So we come right up to the perforation as inferiorly as I can get. So I can get a little width of the flap. And then we come from the superior edge as well. And we'll join the 2 flap margin, the 2 incisions with a vertical incision at that perforation area. So that's coming anteriorly, and you see the turbinate. We are still quite far from the mucoperiosteum, the mucocutaneous junction. So now is that part where we elevate the 2 flaps and trying to keep both sides intact, because I need the same thing on the opposite side as well. So for this part, I do need assistance from my colleague. So you see a 3-hand approach being used here so that I can dissect and cut at the same time. Fortunately, we were able to get a good flap on both sides. We were able to do this without tearing anything more. Now for me to rotate a shorter flap into this area, it means also that I have to take this middle turbinate. So our next step is then to sacrifice the middle turbinate. So we are cutting it off at the back, and a thought then hit my mind, can I use the turbinate and rotate it into the defect? But it didn't work, so we just took the whole turbinate out. I managed to get a few strips of cartilage from the septum and I used it as a strut. not to fill the defect, but just as a strut to hold the brain from collapsing down again. On either side, we plugged it a little bit with fat. We put in some glue here just to make sure that all stays in position. Because of the weight of the brain also, you see there's no significant anterior leak, active leak. And then we could rotate the flap, and I think this patient was extremely lucky that it all just worked out well. We got a nice, thick, robust flap, exact width, exact length. We wanted to keep the frontal sinus open. We wanted to keep the maxillary open. So the flap had to come all the way from orbit to septum, but keeping the frontal sinus open anteriorly and the maxilla laterally, and yet cover the entire defect without any problem. So we did this on both sides, and it took us about, I would say, a little more than 5 hours to do this. Kept our fingers crossed, and this patient did well post-op and could go home. All right, so when you're operating, what are the precautions you will have? Anatomy is the key, and unless you have a good anatomy, please do not go ahead and do CSF repairs. And for that, you need triplanar scan. There's no shortcut on that. Do not have a limited CT scan. Certain pathology like AFS and tumors will cause erosion of bone. Be a little more careful, especially around the area of the middle turbinate attachment. When you're using forceps, try not to pull very aggressively, and power instruments with a gentle hand as you use it towards the skull base. If you do have a leak, realize it, identify it, and repair it. Do not try and do an ostrich approach by hiding, pretending that there is no CSF leak and everything will be okay post-op. Your best time to repair it is then. So let's look at a few. So these are the standard cases. So let's look at a few difficult situations or difficult cases. So we go to the ethmoid. Now this is a much bigger traumatic leak, much bigger defect, junction of ethmoid with the sphenoid sinus. This is one of our very early repairs. This is maybe early 2000. So there was no description of a Haddad leak. Otherwise, I would have done of a Haddad flap. Otherwise, I would have done this with a Haddad flap. So ethmoidectomy is done. You're seeing posterior ethmoid here with brain tissue that had been blasted through the defect, and you're seeing pulsations. We're just opening into the sphenoid sinus at the bottom, and there you see is the sella and the sphenoid. This is then the posterior ethmoid with a big defect, and as I would clear the brain from that area, you see the optic nerve coming into view. So a bit of an Ono-D cell situation, optic nerve, sella, and the sphenoid. And then as we cleared all this dead brain tissue, the mucosa and everything, we could then define a nice large defect in the back of the posterior ethmoid. So big defect, big piece of fat. Again, very early days, we were not familiar with either the flap or even a bath plug. So just a big piece of fat. On top of that went a nice big piece of cartilage. Your cartilage has to be just that 0.2 mm bigger than the defect size, so that once it goes in, it doesn't fall out again. A smaller piece will not work. Make sure that it's sitting well and covers the whole defect completely. And then once you got security like this, then it's quite easy just to put an overlay fascia, and you can put a bit of glue on top of it. So this was a big traumatic leak. Frontal sinuses, to do it, and I'm quite happy to do frontal recess leaks. But if you have, like in this patient, a posterior wall fracture, big traumatic leak, then I find even if you do a Lothrop procedure, it's going to be difficult to repair. This particular patient had 2 defects, one frontal, one posterior ethmoid. So we just had to do a semi-Lothrop to identify and figure out whether there was an active leak or not in the frontal. But a well-pneumatized frontal for me is not my cup of tea. Let's put it that way. I know there are many ENT surgeons who would like to do it. thing, but for me, just to reach a posterior wall and effectively remove the mucosa without a real struggle is not worth it for me. And then to make additional holes in areas to support other instrumentation, again, doesn't make sense as compared to having just a simple bicoronal incision, elevation, pericranial flap, and the patient is out and on his feet without any nasal morbidity. And mind you, Lothrops do give a lot of nasal morbidity. So I'm actually not going to take you through this video because I don't advocate so much. I'm not comfortable so much with frontal sinus repairs. But let's look at this case. So frontal recess or supraorbital. Now this is a more contained cell. So it's easier for me to remove this mucosa as compared to removing mucosa of the entire frontal, right? So let's look at this empty cellar syndrome, as you would see in a spontaneous leak. And we are on the right side. I'm just going to pause here again. I think we have some issues here. Yeah, Mar. Okay. Yeah, I'm doing that. That participants, no, I need to check. Yeah, I did. Okay, I'm doing that every 5 minutes. Okay. Sorry, guys. Amar just requesting me to check for anyone waiting. So let's just go back. Right, so let's go back to our supraorbital. We're on the right side. That's our defect, quite a large defect. Again, the route will be the same. We have to do a full ethmoidectomy. We do a good frontal opening, identify the supraorbital, and then go in. So this is steps of FES, which I think everyone's familiar with, and I won't waste time with this part. So, okay. Let's go back a bit. Okay. So ethmoidectomy is done. You can see the meningoencephalocele coming out, frontal sinus above, through that defect in the supraorbital cell. So it's quite a large defect and quite a large meningoencephalo, as you can see here. So we're going to be using angled scopes. We're going to be using angled instruments. That's the anterior ethmoid artery below you, frontal sinus opened well above you, and supraorbital cell from where the defect and the meningoencephalocele is. Right. So it's not just good enough for me to remove this thing because I then need to identify the bony defect. But as you can see, I also need to remove the entire mucosa around it. And which is why I struggle with the frontal sinus in this aspect. So now you can see that the bony margins of the cell coming into view completely. We've removed very well all the tissues, and we just remove the last part of that encephalocele. So it's quite a large bony defect. Now I'm little unable to see that lateral part yet. So I'm going to drill this obtrusive bone in which is coming away, which allows me then to get in and see it a little better. We are with a 70-degree scope here. So I see the defect. I'm saying all of you can see the defect, but am I sure that there is no mucosa in this recess? I don't want a mucosal formation. I want my graft to stick well. And that is the reason why I have to drill and ensure that I have removed everything completely. So once that's done, then I can plug it with a piece of cartilage if required. If there's no active leak, or if I'm happy, then I can just plug it with fat and then put a piece of fascia on top of it. And then the rest of the repair is pretty similar. The care that you're taking here is that your frontal sinus remains open. So be very careful. You don't want to layer the whole thing, which is why your frontal sinus opening has to be wide, has to be as wide as possible, so that you don't inadvertently have an iatrogenic frontal sinusitis. And then we just put a little bit of fat to secure everything in position, gel foam, and pack. So you must have angled burrs as well. And Medtronic, I think that's why it's very good in terms of a debrider, because it gives you a variety of shapes and angles, even with burrs. And so to have a 40 or a 70, what we call a frontal finesse burr, is very important in situations like this to drill that bit of bone. Let's go next to a sphenoid lateral wall issue. Again, I'll just check if everyone's here. So we have actually got one of the highest series internationally of this, and we are in the process of a publication. We've done about 40 of these patients now. And these do have their own issues of what we would traditionally call a Sternberg's canal leak. Some debate regarding what is actually a Sternberg's canal. But generally, when you have pneumatization of the lateral recess, and you get a leak there between the V2 and the median, in that area, it's the lateral wall. So many ways you can do this, right? This is one of the ways that we have done. The inferior turbinate is sacrificed for two reasons. If it is very bulky and you need space to operate, or if your defect is very low. And you can kind of judge that on the axial views. In most cases, we would not take the inferior turbinate. We would leave it alone. Of course, you have to do a fess as you would normally do. So we're just uncinectomy done, opening up the maxilla has to be opened wide. You want a clear view of the posterior wall of maxilla because that needs to be partly removed. Go back and remove everything else. Now you're going to communicate the ethmoid with the sphenoid, or the maxilla and the sphenoid must be seen in one view. To do that, it's imperative to remove the middle turbinate. There's no way to save the middle turbinate because the ground lamella comes in your way. Once that's done, now you have a full view of maxilla to sphenoid and the pterygoid, behind which is going to be your defect. So we're just clearing up the tissue in this area now. We have posterior maxilla. My punch is in the pterygopalatine and I'm just widening it. That will then allow me to clearly define the sphenopalatine and I can cauterize it. You can do this uninostril, you can do this binostril. It depends on your comfort, it depends on your instrumentation. Usually we tend to go binostril because the drilling is easier, especially if the defect is very lateral and there's a lot of drilling required. If it's not very pneumatized, I would go unilateral. Can we take a flap on this side? No, because you've sacrificed the vasculature, the sphenopalatine. Can you take a flap from the opposite side? Yes, you can take a contra flap, but it has a long distance to travel. And so is it really required? Generally speaking, we've done about 4 or 5 of our patients with flaps out of the 40, but otherwise all are free repair. So in this patient, we want to do a binostril. So we need a posterior septectomy. So the posterior septum periosteum on the affected side, I'm going to take out as a free graft and save it for use later on. On the opposite side, I'm just going to make rescue flap incisions. And I think this we'll cover when we do skull base surgery or skull base reconstructions. So we just do these 2 incisions so that the flap or the pedicle remains intact. At the same time, you can lower the periosteum, take out the bone posteriorly, and it allows you binostril access. So if I want to use a flap, I have not taken away that option. If I don't want to use the flap, my flap will come back at the end of surgery and I will not have a big hole or a septectomy at the end. It will look like a normal nose. So that is the advantage of this approach. Or you can even take an anterior incision, like an SMR incision, elevate the whole mucoperiosteum from there, especially useful if you have a bad deviated septum, and then use that as your port for a binostril. So we are then taking the rostrum out. So we take the rostrum out, we open up the sphenoid wide on both sides. Okay, it gives you a view of the sella on both sides. You can go a little quicker. Keel comes out. You just want nice space to work with, right? You're going to get 3-4 instruments in there. So let's get space out. So once all that's done, you can then go in and start drilling. So you want to do a transpterygoid, transmaxillary approach to the lateral recess. So we lower down that pterygoid wedge and we take the posterior lateral wall. This is judged depending on the pneumatization of the lateral process, how lateral the viewing is required. Once that bone is removed, identify the internal maxillary artery, and you can either clip it or you can bipolar it. It really, your choice is yours. From here, you also see the descending palatine artery, behind which will be the palatine nerves. So sometimes they need to be sacrificed, but as far as possible, we will try and preserve it. So that's just our artery. In this case, we just decided to cauterize it. We had one patient in whom the clip slipped post-op, and so we're a little wary about that. So we just cauterized it. And now we can come back to this area. So that, okay, let me just go back a little bit. Is your lateral recess. You see only a little bit of the meningocele in that area. So unless you remove this entire bone, you will not have a good view of that defect. This is the lumen of the internal maxillary. This is the descending palatine. This is the sphenoid, the sella. This is the junction of the pterygoid with the sphenoid. So you need to remove this. Over here will come the palatovaginal. Over here will come the Ovidian nerve, right? So now we're going to drill down this bone of the pterygoid sphenoid junction. Once we get all that, and we're actually going to drill this bone out under the Ovidian nerve. So we're going to be going around and under the Ovidian nerve and taking out as much of this bone as possible. So once that's done, we now have a small pharyngeal branch going into the palatovaginal, which is cauterized and cut. And just lateral to that, you will be able to identify then the Ovidian nerve, which is more or less parallel with the medial pterygoid plate. So that's your Ovidian nerve now coming into view. As you can see, we've drilled this bone out. We still have an incomplete view of the meningocele, so we need to drill a lot of bone further. Our aim in these surgeries is not to obliterate the sphenoid, it's to plug the defect. So the mucosa is elevated but not removed. And then I can drill down that intersphenoid septation a little quicker. And we can come back to removing all this bone from under the remaining pterygoid wedge under the Ovidian nerve. So once that bone is, oops, I'm sorry, let's go back. Let me catch up with you where you are, right. So once that bone is gone, you can see that you now opened into the lateral recess. This is the entire Ovidian nerve now, completely exposed for you. So we've gone under it, removed the pterygoid wedge, and now have a direct view into the lateral recess. So instead of just that little view, you now see V2 completely. You see foramen of rotundum. So that's your upper limit. You don't want to remove more bone than that. The Ovidian nerve, of course, will get sacrificed. I mean, you can't save it because unfortunately it comes right in your path of access. So the Ovidian will get cauterized and cut, but that's the Ovidian nerve being cut. And now you have a full view of that entire encephalocele of the lateral wall and even the part which is lateral to the defect. So now I can sort of go around, define it, and remove it. So I'm going to go a little quicker here. So again, bipolar cautery, cauterizing the neck, and then we can remove the encephalo. And these are always large meningoencephalos. Even though you feel that the bony defect will be equally large, the bony defects are not so large. Mucosa lateral to the defect, very important, as you saw from the supraorbital, to remove that. And therefore, you need this wide exposure. Any surgery that you can do with a 0-degree scope is going to be an easier surgery. So a good access here allows you exposure and 0-degree usage. Plug with fat, and then in this case, sorry, cartilage, fat, and in this case, we then used our septum perichondrium. From this side, we decided that we had a good closure. We didn't need a flap. It was very lateral. And this nice thick mucoperiosteum worked beautifully. Just just a word of caution, make sure the mucosa is on the outside, the periosteum is on the inside. So you could mark it with a little methylene blue when you take it out so that you don't mix it up later. And then that sits really well. So on top of it, you can then put fat, fascia, gel foam, and close it up. Your mucosa of the medial part can come back so that your healing is good, morbidity is less. Right. So let's go from here into our next patient, which is a clivus leak. Another very interesting patient. This patient had a history of meningitis and fever for a month, admitted at a different hospital and given treatment for typhoid, malaria, dengue, TB, all sorts of things, because they were not able to see or identify any other reason. All the coronal scans showed no defect. And so the patient had intermittent watery leaks, they were not able to say it's a CSF leak. They couldn't collect enough for a beta 2. And so when the patient was transferred to us, we did the obvious thing, right? Triplanar scans. And immediately, both your sagittal and the axial showed you defects in the clivus, which a coronal could not show you. So we went in and this is what we did. Otherwise it was straightforward. The trick was only an identification. So because it's a clivus leak, we don't need a very long flap. So we do what we call a mini flap or a shorter flap. On this side, we don't then need a reverse flap because I'm not going to come all the way onto the cartilage, or we just take a little bit of cartilage which we can then trim. So just a little bit of cartilage which can be trimmed off, and so that will negate the necessity of a reverse flap. We then open the flap elevated. The posterior septectomy done. So I do want a good exposure here. Okay, so that we have a nice wide opening into the sphenoid. Mucosa is removed. Sella you can see very clearly, and that's your site of your defect. So mucosa is removed from all around it and necessary if you want to put a flap into position. Now, because there was this small meningocele coming through it, we cauterized it and we tried to plug it, but we found it was not, the bony opening was too small to plug. And I did want to plug it. There were also additional defects. You can see one inferior, one behind the sella. So we trimmed the bone off, we drilled the bone off the sella to gain access to that small defect here. So one below, one above, behind the sella. And then, let's go quicker. We cauterized it. Like I said, the bony defect was too small. So I actually had to take a drill and widen it a little bit so that I could plug it effectively, because this was not allowing me to do anything. So that's just a little widening, and with extreme caution, because once I remove the drill, you'll see what's behind me is not just the defect, but the basilar artery. So that's how close it was to us. But with a bigger defect now, it's much easier to plug it with a bath plug. So we're using a bath plug here. So you can see that there's a string tied to the fat. So the part which is tied on the top and then through the fat, the top part is introduced first, and then the string is pulled so that the fat sort of telescopes onto itself and jams it into position. And then we put another piece of fat in the upper defect, a little more fat around it, and then we could put our flap back into position on top of this. So this worked out well and this patient did well. Sometimes it's just a little bit about how you sort of approach it and how you close it. So a middle cranial fossa leak, a much bigger leak, a little different from just a lateral sphenoid CSF leak. And I'll go through very quickly this, but you see the pterygoid on this side, you see the pterygoid on this side. It's expanded and it's full of CSF, as you see on the MRI. So it's kind of a pterygoid cyst, we would say. We don't know the etiology, but this patient presented with epilepsy or convulsions because of the middle cranial fossa effect. And the scans were done for that. There was no active CSF leak. So the initial steps are pretty similar, and I can run through this to a lateral sphenoid, which means we took a free fascia, free mucoperiosteum, middle turbinate is gone, maxilla is opened, inferior turbinate is removed because it's very low, maxilla opened wide, sphenopalatine identified, cauterized, sphenoid sinus opened. And the moment we started sort of drilling into the pterygoid, as you can see here, we got this big gush of CSF. So this is of course the posterior wall of maxilla being opened up, bone removed, IMA will be identified. So that's your IMA now being dissected. And we wanted to go as lateral. So that's your entire artery now dissected. And that can be clipped or ligated. And then we drilled the pterygoid. And the moment we got into that opening, you see it was just an empty space. And there's a lot of CSF that gushed out. And this defect goes all the way to the temporal bone. So that's V2, that's Vidian below us, which is already dissected for us. The cyst had done everything, V2 here. And a huge, huge defect here. Some parts of bone there. So descending palatine here. And now we are way below the Vidian nerve and trying to remove as much of the mucosa as possible. I'm going to go a little quicker. The Vidian nerve is sacrificed here. And we still needed more space because the defect was actually superolateral to the V2, not just between V2 and Vidian as you would see in a normal Sternberg canal leak. And so we also had to do an additional step here. So I drilled the bone around the descending palatine to retract it without sacrificing the nerves. And then we elevated the rotundum, the canal, and uncapped the V2 a bit. To give me a little more space for that, I could push V2 up a little bit to allow me to see the defect itself. And we are, of course, using angled scopes even at this stage. So you can see how far lateral that defect went. I mean, it was incredible how far lateral. But fortunately, the defect for us here was here. So we could remove mucosa around that area, cauterize the encephalocele, V2 above us, defect here, and then we could put in a nice big piece of fat into this area and plug completely the defect. And this was very important because there was, and this had to be done completely single-handed because there was no way with a 70-degree scope that I could get assistance. So the whole operation had to be done with with one hand with the endoscope. And on top of that, we put in the free mucoperiosteum. So that's how this repair went. Similar, but a little more difficult than a lateral recess. Right, so I think we leave this for another time, right? For the reconstruction of skull base. I won't do it now, since we are staying with just CSFs. So these were some of the conflicts earlier. I'm talking of in the early 90s, so almost 25, 30 years ago when my professor, Dr. Kirtane, started doing CSF leaks, it was virtually unheard of. This was in 92, 93. And the neurosurgeons were up in arms as to why ENT is starting to do endoscopic CSF leaks. It's wrong, it's unphysiological. How can you repair your teres, leaking teres from below? It has to be done from above. Now, of course, we know, and the neurosurgeons are very cooperative and helpful and will refer that yes, it can be done from below. Large breaks are indeed difficult and will need additional help with cartilage, bone, or vascular flaps. Frontal sinus does require technically very difficult. You must be a very experienced and skilled surgeon. For me, an external approach is usually in a hypo-pneumatized or a poorly pneumatized frontal sinus. I'm happy to go endoscopic. In a well-pneumatized frontal, I would prefer to go with a bicoronal. Multiple bilateral breaks, again, for me, would be a transcranial. In non-active leak, where there's a history of meningitis and maybe an occasional intermittent leak, is very difficult, especially in the absence of a proper defect on CT scan. And this can be a very difficult situation as to how to repair. Whether you repair one side both sides based on the history of water, which area to repair, etc. Fluorescein might be useful in these situations. And of course, where you additionally have a or intracranial pathology, will you then just want to do the repair intracranially if they're going to open up the head for some reason. So for us, again, sodium fluorescein is used only in very selected cases. We don't tend to use it all the time. There is some fear of reaction with the sodium fluorescein. It does add almost 45 minutes to an hour of extra surgical time, because you need to then inject it slowly and put the patient in a head down position for a long period of time, and that very small risk of getting an epilepsy or a convulsion post-op. So in situations where we feel that it's difficult to get localize the leak, revision leaks, this is one such patient, CSF lateral recess, 5-year-old boy, congenital dehiscence. We repaired him in 2015. He then migrated to Australia, where he got an episode of meningitis. They scanned him, could not find any leak on cysternography. Let him be. A couple of years later, he got another episode of meningitis. Check endoscopy is done, check scans done, again failure to find a leak, you know. And the boy was in contact, the parents were in contact with us in Mumbai. And then last year they came back actually to Mumbai saying they have now a third episode. And so we could still not demonstrate a leak on, we knew there was a big defect, but it had been repaired at that first time. And even on the cysterno, we were not seeing any dye or any sort of, on the MR cysterno, anything coming into the nose. So in that case, in his case, we went in with a fluorescein. We kept him head down for 30-40 minutes. And as you can see, we had staining of fluorescein. So that was immediately reassuring to us, because we knew then that we could trace the fluorescein and follow it and get an idea of where it's leaking from. So that's what we did. It's on the left side. And gradually we come from, the stain had gone all the way from maxilla to eustachian tube. So we had to sort of take mucosa off in all those areas to see which of them actually led us to the defect. So we're using a coblator here just to remove the mucosa. It also is very useful, we found, to sort of take off the stains and prevent us from chasing areas which otherwise were just stained and not. So like the eustachian tube, right? It felt like, there's a lot of staining here. But there was nothing coming out. So we knew that the temporal bone was not a source of the meningitis. And then we could come anteriorly to that, and at the inferior aspect of this pterygoid repair earlier, we were then able to chase it in and locate the CSF leak. So you can see that with the flow of CSF now getting more localized and stronger as we start removing or tracing the fluorescein back towards that area. And the coblator is a wonderful instrument. I think it's for its ability to cut, irrigate, and suck all in one hand is wonderful. It works very well in some situations. So here you can see now that we are following it back. One of our concerns was there's a huge bony defect and we didn't want to open up the whole defect. So how much of it do we open? How much do we chase before we decide to reclose it? So we wanted to be sure that we have something that we can plug before we abandon. And there was a lot of leak of fluid here. And then we drilled a little bit again. Again, we're just trying to follow as much of it as possible. Let's go a little ahead. Again, we have a higher flow of the cysterno. And then we start coming to an area where we can actually see like a more pinpoint opening. And once we could sort of cauterize that area, then we could stop the leak. Actually, you could stop more fluorescein from coming down. And we said, okay, now this looks good. So we plugged that part. Now you can see there's no fluorescein in the field at all. We could plug it effectively with a bit of fat. There was already a Haddad flap used for him in the first case. In the first situation, because the defect was very large, we had used it even though he was 5 years old at that time. He's 9 now. and we used a fascia on top of that. And at least in this last 6 months, this boy seems to have done well. So just an example of fluorescein. And just to end with a note of thank you to Dr. Kirtane, who has been, in my mind, the pioneer internationally for both for FES and especially for CSF repairs. He's done an unbelievably large number of CSFs, and for us, for me, he has been my guru for endoscopic sinus surgery. Learned all my basics under him at KEM. He continues to be our guide and mentor, and always a person we can go to in times of when we need help. Thank you to everyone who's been kind to attend this webinar. And Amar, if there is time, then I'm happy to take questions. Thank you to everyone. I think instead of allowing vocal questions, maybe we just ask people to type in if there are any questions, and then I can answer the questions on type. So in this, Amar, if you can.
Okay, thank you very much.
Give your feedback, yeah.
Okay, thank you very much. This is really more than excellent lecture about the management of the CSF rhinorrhea and all the approach, starting from the anterior to the sphenoid to the lateral recess. Thank you very much. It was very informative to me and our audience to share your big knowledge and experience in this field with us. About the questions, I will proceed to the many questions that was written down in the message bar, and after that I will proceed to also the questions that written in the Facebook live webinar.
Okay.
Thank you. There is a question asking about the Haddad flap. Asking you that do you have Haddad flap or rescue flap, because these are vascularized flap. If not, why? What you prefer?
So Haddad flap is is a beautiful flap.
Yes.
It's a vascularized pedicle flap which gives you so much security in terms of repair. But we must not forget that it's also an extremely vital resource. It is also associated with significant morbidity in the nose. So we do not want to take a Haddad flap for small defects which are easy to repair with free repairs. And we have seen now from various studies done over the last 10-15 years that the statistics do not show any difference between a free repair and a Haddad flap for small repairs or small leaks. There are only leaks which are large leaks or high pressure leaks where the Haddad flap has a definite advantage. Keeping that in mind, I would like to save the Haddad for a future event if it is required, whether it is surgery or a traumatic event or whatever, and also reduce morbidity to the patient.
Okay, thank you. There is asking you, are you using intraoperative image guide and 3D reconstruction software described by the Dr. Warnold?
Yes, we use navigation only for certain situations, not for all situations. Like the lateral recess of sphenoid we use sometimes just to know. It gives you an idea of how much of the posterior wall to remove, because you can sort of extend your pointer in that direction. For frontal recess and supraorbital leaks, because again, sometimes they're a little tricky and it's nice to have a navigation. But in a majority of patients, we will not use navigation. I would say 95% we would not use navigation.
There is another question asking about the functional deficit after meningoencephalocele cauterization. Is it due to gliosis?
functional deficit. No. So usually what comes into the nose or into the sinus is dead tissue. And so our neurosurgeons will tell us quite happily that you can take it out. Don't worry about it. Is dead tissue. It will not affect or affect the patient in any way. There's going to be no deficit.
Yes.
So you are doing an MRI for all encephaloceles. You are confirming there is no vital tissue, vasculature, nerves prior to surgery. So we've had defects, like for example, where the entire planum is gone and the brain comes down. We've had patients with the optic nerves, with the thalamus coming down into the nose. Now, if I do that kind of surgery for that patient, this patient is dead. He'll never wake up.
Okay.
So you have to confirm that the tissue that you're going to remove does not contain anything vital. Yes. Which is why it's very important. You know, for us, Amar, we do all our skull-based surgery with neurosurgeons.
Yes.
Most of the CSF repairs you can do comfortably yourself.
Yes.
It's not necessary. It's not essential. But I find working together with neurosurgery, it helps us in so many ways. You find different instruments, you find different techniques, you find different thought processes. And in many ways, it helps you build that team bonding that will work towards doing bigger surgeries like meningoceles or chordomas, meningiomas or chordomas.
Okay. Sometimes the CSF may be a high flow. As you know, there is a
Yes.
low flow and high flow.
Yes.
Your opinion about the shunt operation at the same time or multiple acupuncture?
Yes. So that's a very good question, and I should have addressed it in a little more detail during the talk.
Okay.
Almost always with spontaneous CSF leaks, you'll see an empty cellar. Your typical patient is middle-aged, little bit of obese, signs of raised intracranial pressure. Now, for us, when we do a CT cisterno, we will always request the anesthetist or the person who's doing the lumbar puncture to measure the pressure at that time. And that pressure measurement gives us an idea. If it's like in the high 20s, we are more worried. If it's in the low 20s or around 20, we're not so worried. That will dictate to us at the time of surgery whether we need to put in a lumbar drain or not. It will also tell us about the possibility of or need of a shunt for future. So generally, we would not put a shunt in as a primary procedure. We would do the repair, but if the patient leaks and we find a sustained high pressure, we would have already counseled the patient at the first surgery that your pressures are very high. There's a slightly higher possibility of surgical failure. If that happens, we will shunt you the next time.
Thank you very much. Nice. There is a question from Dr. Umar Rawi. He is asking about the name of your bipolar forceps that is used.
This is the Dr. Nishit Shah bipolar forceps.
Okay.
So seriously, this is a surgical company that came to us earlier,
Yeah.
and they were using these sort of forceps for laparoscopic surgery.
Yeah.
So we modified the whole instrument so that we could use it in the nose. And it's very nice because it has a rotation, a 360 rotation. So your angled tips can now rotate 360 degrees. We have one that's horizontal opening, one that's vertical opening, and one that's straight. But now I think it is also made commercially by Santosh Surgical and Kalilkar. So for those who want to buy, can buy it straight. You all don't need to give me any money for it.
Okay, thank you. It's very nice. We want, please, you can show us your instrument in the future. I think there is not a lot of question there, but as you know, all the audience want to tell you thank you very much for your nice experience and sharing your knowledge with us. And we are looking for the next lecture about the reconstruction of the skull base and how to deal with the cases of meningioma or meningoencephalocele.
Sure. Thank you, Amar. Thank you, everyone.
Thank you very much. Happy Eid. Thank you.
Thank you. Happy Eid. Yeah. Happy Eid to everyone.
Thank you very much.
Bye.